Thank you, sir. Very good afternoon to one and all. We are in day 5 of the series of research webinar, Building Heterogeneity in Research. So we had 4 lectures so far, and it has been exciting and very interesting for the audience. Now we are in day 5. We have an eminent speaker today for giving us a share of his research experience. I welcome all the participants. At the outset, I would like to welcome our Dean, sir, who couldn't join because of some other commitment. I welcome Director Medical Research, Dr. Vishnu Bhatt, sir, Dean HP, Madam, Vice Principal, and beloved speaker of today, Dr.K.A.Narayan, sir. And last but not least, I welcome all the participants who have joined in this afternoon session for gaining much knowledge about the research experience from sir. Now, we have been going through a series of research webinars starting from the scientific manuscript writing by Dr. P.F. Kottur, sir, and then where to publish by Dr. Saurabh Srivastava, sir, on day 1. And then we had Dr. Sitaraman, sir, speaking about systematic review on day 2. And then we had Dr. Pankaj Shah, Professor and HOD of SRMC, talking about meta-analysis in literature. And on the last day before this session, we had Dr. Mahalakshmi, Madam, Professor of Community Medicine, JIPMA, speaking about qualitative research. I would like to summarize or recap about what Madam has told on that day for the benefit of the people. Madam started with differentiating between qualitative and quantitative research. What is the advantage of qualitative research over quantitative research, and how numbers cannot make all the magic, where you need exact statements of people to be reflecting on your research. She also talked about the inductive versus the deductive approach in conducting qualitative research. Madam also highlighted about the research cycle. She also highlighted about the sources of qualitative data, and we had a Mentimeter session on that. And Madam also highlighted about 4 important approaches to qualitative research, namely phenomenology, ethnography, grounded theory approach, and case studies. She also gave a very interesting note about the content mapping and uses of softwares in qualitative research. So we had a very interesting session on that day, and we also are very grateful to Madam for sharing her experience. Now today we have amidst us, we have a speaker for this today. Before I introduce the speaker, I would like to ask our Director Medical Research, Dr. Vishnu Bhatt, sir, to share a few words.
Good afternoon to everybody. Dr. Narayan, my former colleague, and of course now also is my colleague in a different place. So then Dr. Mahalakshmi, Dr. Daniel, Dr. Kumar, and other senior faculty members. And I think we are going in the right direction. And because of COVID, we thought why not explore other areas of research and publication, because the publication has become part of life now. Whatever it means, people want how many papers you have published and whatever. So with that idea, it has started, and we have covered many areas. And I think Saturday we have 2 more topics to be covered. And what we listen is not that important. After what we do, following the listening is more important. So we are looking at the outcome. Already 3-4 workshops conducted, but there is definitely interest among people, but not up to the satisfaction. But I am sure that in days to come, people will do a good job. And I welcome Dr. Narayan, who is well known. He has been in Malaysia after JIPMA. JIPMA also, he was heading the Department of Community Medicine earlier. So I want to listen to him and also learn from him, like you all. So, thank you very much.
Thank you very much, sir, for those friendly words. And I think Madam is unmuted. I'd like to share a few words, ma'am.
No, we are very interested to listen to cancer after a long time, and we'll directly go into the session.
Okay.
You can
So,
introduce yourself. Thank you.
I'm happy to introduce sir. Let me share the. Hope you can see my slides. So today, the speaker for today is a great man, Dr. K.A.Narayan. He is a professor of Department of Preventive and Social Medicine and Medical Education Unit at Mahatma Gandhi Medical College and Research Institute, Puducherry. Sir has done his undergraduation as well as post-graduation from JIPMER, Pondicherry. Sir has contributed to the development of undergraduate curriculum in community medicine and many other subjects in MBBS. Sir is a faculty of National Teacher Training Center, NTTC, a resource person and organizer for a variety of workshops ranging from pedagogical methods, management, hospital-based management, and disease surveillance. And Sir was a faculty of community medicine at JIPMER till 2006, where he was given the head of the department to head the department. And Sir has been trained in statistics for health at University of Reading, United Kingdom, under the Commonwealth Fellowship. And Sir is also trained in qualitative research methods by WHO. Sir was the establisher of JIPMER Computer Club and setting up of the telemedicine facility at JIPMER. And he played a key role in computerization of the Department of Community Medicine, the networking of JIPMER, and established a computer laboratory and telemedicine facility at JIPMER. And Sir is a member of High Power Committee for developing the plans for expansion of JIPMER. And in 2013, after his tenure in AIMS University in Northern Malaysia, Sir returned to India and joined Mahatma Gandhi Medical College and Research Institute as HOD and was given an additional responsibility of Vice Principal of the college. And Sir has been since then a great resource person for Health Manpower Development Unit at SBBU, which trains health professionals in educational sciences and in setting standards for teaching and evaluation. Sir is a faculty for postgraduate diploma and MPhil programs in health professional education and for courses in research methods. Sir has been a co-author in copyright for 7 programs at SBBU, and we can keep on telling more, but for want of time, I want to leave the stage entirely to Sir, and we welcome you, Sir, and we are happy to listen to you for the very nice session on population-based research. So today, research has become more into computers, Google Forms, and this is one era where we have to remind back about population-based research and what entirely the field research means to us. And Sir will be the best and apt person to enlighten us on this. Sir, stage is yours. Thank you.
Thank you very much for those kind words. I think you lauded me a lot, which I think they're more than I deserve. Firstly, I should thank Professor Kotur for giving this opportunity, along with Dr. Mahalakshmi and Dr. Vishnu Bhatt, with whom I have worked for several years now. Of course, Dr. Vishnu Bhatt goes back to student days, and from there we have been working together. And Dr. Mahalakshmi, we did a lot of innovation, especially in medical education and Mahatma Gandhi. And so as far as the field of population-based research, of course, I did a lot of work with research, and I have my pet peeve that it is not a cup of cake for everybody. When Dr. Mahalakshmi was saying that we have to show, go on showing research, I said universities also have to know it's time that they push back and say research is fine, but it's not that anything and everything is research. It has to be quality and not quantity, and that it should not be the only parameter which ensures career enhancement, because then that vitiates the whole process. And as Dr. Vishnu Bhatt said, it is more of my repetitions or failures I would like to share than some true achievements. Of course, there would be some which I have invited Dr. Shiva Naik to be with me as one of the, because first of all, it was a 2-hour slot and I do not want to occupy the full time. So we thought we'll share some breakup because the number of participants were high. So workshop mode was not very feasible. So we have opted for a different way of interacting with the audience. With that, I'll start sharing the screen. I'll jump straight away into my presentation.
Sir, before you start, just one announcement that we
Yes.
are recording this live. Sir. The YouTube, it is going
Sure.
live and it is there.
Oh.
This is for academic purposes. Thank you.
Okay, sure. Thank you. I'm sharing my PowerPoint. I hope it's visible.
Yes, sir, it's visible. Yes, sir.
Right. The first dilemma of what we have with numbers. So recently, this is from the number of vaccine doses which were given, and there's a lot of noise about the number of doses given by India, and we have exceeded the number of doses given by United States by a whopping 3 crores, and we were patting ourselves on the back. You know what happens when we ensure a target. What's the problem with this? Anybody, any participants would like to tell something or put in the chat box? What's the problem with this figure? 37.6 crores and 33.4 crores. And what is missing is this column. What percentage got vaccinated? And if you see, it's only 5.3% of the population as compared to 48.4. And this is the biggest dilemma that we have in with the reference to numbers, that the population figures are not given. Yes, I'm getting some responses that it is, and somebody has mentioned survival also. I missed that. So basically, we do not have a denominator, and mostly we have numbers. So often we have this difficulty, and that is one of the first dilemmas when we come to population-based research. What is the population we are talking about? Because without that, it's just numbers, and then comparisons are difficult. And when you look at it some other way, then we have an equally big population, but they have vaccinated almost 4 times the number that we have got, China. So these are some of the issues which are now currently we are facing, and that's the way forward. So I'll be talking about, the title given to me was population-based research, but I will also expand it to what is called public health research, because population, often it falls back onto, it is internationally also called public health research. Internationally also called public health research. I have some feedback.
Sir, I have muted, sir. Please go ahead.
Okay. Right. So now I'll be sharing some issues with that. This is what I'll be talking about. What are the issues when we talk of population or public health based research? The challenge of data and the quality of data sources, the data challenges, what do you do with the data, what are the study designs which are there, and some of the ethical issues. I'm not restricting myself to pure research. I'll be expanding to the concept of service-oriented research from hospitals to also in public health. And I have a disclaimer here. Some statements I may be making are more of my personal interpretation or opinion, and it's open to debate. So, of course, I've gleaned much from literature, but how I interpret certain things may be open to debate. So, the first dilemma is, how do we define what is health? So that itself is a dilemma. And often we say it's absence of disease or symptoms, and this fits better with allopathic medicine because it's on negating symptoms or treating disease. Whereas the population or public health emphasis is a preventive measure addressing the root causes rather than the symptoms, and it's health promotion and well-being. So this is a major shift between what is clinical medicine, where it is you have some symptoms, you can see something is wrong, to the other side of the spectrum when people say, well, I have no issues. And in fact, the WHO itself had a lot of difficulty in framing or defining what is health. And this is a definition of health. This has been debated a lot. It continues to be debated because certain elements are missing in this. For example, spiritual health is not accommodated in this. We have debated, and yet we have not come to a conclusion or come up with a better definition of health. So health itself, defining health itself is a major issue. So then we go on to how do you measure health? How do you research on health? So population-based disease research is often on health issues rather than disease issues. Of course, both go hand in hand. The other dilemma is, what is public? When you talk of public health, what is this term public? And often we say that these are the activities done by the government. And in the recent pandemic, which is there, everybody is looking at the government for policies, for actions, to control whatever thing is falls under it is viewed as government. But if you expand the scope, there are two primary meanings, and each has got three senses. Public can mean population-wide, referring to the epidemiological measured health of population or group, the distribution of health in a population, or the underlying social and environmental conditions impacting everyone's health. The other view would be that it is something which is done collectively. And to reach certain goals, you do it collectively. And it's a concerted action, not only by the government, but also by other agencies, non-governmental, with the involvement of and cooperation of the public, or by public meaning with the people. And it's a joint participation to realize the overall objective of improving health. So there are no boundaries. It's a very broad definition which is encompassing many aspects. So that therefore it involves several activities. Some of them have been listed. It goes beyond that, but these are the main activities. And this has been summarized very nicely in a diagram which the 10 main actions for public health, and which involves monitoring health and diagnosis and investigation and assessment. You then inform and educate and empower people, mobilize the community participation, and develop policies, which is the policy development. And then you ensure that everything is enforced by laws, or by providing care, or assuring the competent workforce, and also evaluating them. And the center, all this has forms. It is also, you have to forms the research also falls into place. So these 10 broad elements, including system management, are the ones which are the key activities when we are talking of population-based or public health activities and research. Because if you see here, the research becomes the core of all this. None of these services can interlink unless you have the proper research also. So to define, therefore, public health is a very old definition. It's not only a science, but it's an art of preventing disease. I may sound like taking you back to community medicine class, but this is time and again, we have to re-emphasize some of what we have learned. And 3 activities: preventing disease, prolonging life, and promoting health and efficiency. And how do we do it? Basically, there are 6. It is by organized community effort, and that is the key. And it is done, the 6 main activities are environment, control of disease, education, services, and preventive treatment. And why do we do all this? We do it through a social machinery to ensure that every individual as a standard of living as health. And this was defined in 1920 itself. So that's basically, therefore, what is to set the stage as what is public health. Now let's look at the activities which are there. So public health is actually looking at the bigger picture. In the hospitals, in the clinical settings, we see some cases, but what is happening, like this man, he imagines he's walking down and he sees something and he thinks it is like this. Maybe a naughty picture, Mahalakshmi won't censor me, I hope. But what is actually the bigger picture is something else altogether. So we have to look at the bigger picture. What's happening in the hospitals may be a true reflection of the community, but often we may be misled as to what is actually happening in the community. And that is what is happening in COVID now. We are seeing a large number of very serious cases, but at the same time, there's a huge problem in the community, which people are not realizing, and they are not accepting vaccines. They are politicizing issues. Vaccine supply is a problem. So there's a great mismatch between what is actually happening in the hospitals and what is happening in the community. With that, I like to make a small comparison between what is clinical practice and public health practice. Not to denigrate, many are in the clinical practice in this group, but our public health practice, actually it is a continuum. So if you visualize it as a continuum, then it becomes very easy. Often say, oh, community medicine, that is for community medicine to take care of. No, in the clinical medicine is a reflection of what is happening in the community. Therefore, we pick up from the clinical practice and have to extend it to the public health practice. Only then we achieve a total control of whatever, whether it's disease or health. So the focus in here is prevention, whereas in clinical practice is disease treatment. The target population is the population itself, and whereas it's individuals, and that is one of the challenges. Here it is states and communities, and whereas it's the hospitals. Strategies, you have to, it's multiple times, and you have to keep on reinforcing it. For example, if it's even immunization, you have to go on reinforcing that please take the immunization, whereas it's here is one-time treatment, counseling, and education. The ethical principles which fall behind us are the critical, because we are talking of research and ethics of research. The key ethical principles here in public health are burdens, risks, harms, cost, and equity. You want me to annotate? Okay.
No, sir, I think it has accidentally got.
Okay, thank you. So, whereas in clinical practice, it is patient-centered. And this is the main dilemma between in many issues when we discuss whether both in research and clinical practice, that this goes more towards the general good, utilitarian, the general good for all. Whereas it is more patient-centered, we look at honesty, trust, transparency. Those are the issues which are of driving principles when it comes to both that service delivery or research. Going on, in public health practice and in clinical practice, both have got teams, but here it is the teams are interprofessional, whereas intra-professional, most of the people are on the same footing, and professionals like doctors are probably on the highest level of the team. Whereas here it is interprofessional, people like social work, environmental sciences, health education, all form the team. And the most difficult part is that sometimes the policy is beyond the professionals, going into the hands of politicians or the administrators, and the professional is actually in a lower plane than when you are in clinical practice, and that form causes a lot of stress. Coming to data, and there's a major difference between how we look at clinical practice, because there's an individual encounters, whereas and a patient comes to you, you see him once, it is recorded once. You may have several visits, but each visit is only, you will take the latest visit into account. Whereas in public health and population base, it is multiple encounters, and often you need several encounters to be able to complete a service. For example, if you take immunization, it takes 6 visits to complete the data on whether it's completely immunized or not. COVID, unless you have had 2 visits, you are not given a certificate of completion. For tuberculosis treatment, you have to have several visits to ensure that the person has completed the treatment. Whereas if you take hypertension or diabetes, a person drops out, he'll drop out, but it's not a completion of treatment. So these are some of the issues which come up even with data. And as for a denominator, it is usually optional in hospital-based settings. All you need to do is talk of a proportion, but it becomes essential that you have when you talk of the public health setting. Data complexity is high, but the mechanization or ICT utilization is very low. And that is also one of the problems when we come to retrieving data for research. Whereas in hospital settings, usually the data complexity is low. You can very easily interlink between various aspects of the hospital, and the ICT utilization, because it is driven by often by higher revenue, is much higher. So to summarize, put it all together, what we have is a distinguishing features of public health practice. There's at a lower function, and there's a higher administrative function. And it is at the level of individual, communities, policymakers, and with other sectors. And at the community level, you have to tackle diverse social groups and dialogue and partner. At the individual level, you need to aggregate. This is the challenge, because it's not you have to aggregate all the encounters, and you need to measure the impact and look at the social factors. And with the other sectors, you need to collaborate, and often you have to formulate public health law and navigate the political process. So it's a complex way in which the public health practice has to be implemented. So basically, it's what actually happens is a use of government, a collective action, and it's a focus on prevention, and it is for collective good. And all these interact together for an outcome based, which is called the utilitarian, for the good of many. And that is the research challenge or ethical challenges which we face. So basically, with that fairly long introduction, I'll get into some of the survey results, which questions I had asked you to share. And do we have any questions or comments at this stage before I move to the next stage?
No, sir, we don't have anything in the chat box as yet.
Okay. None in the chat box. Feel free to interrupt or put it in the chat box. And I'll, Dr. Daniel, is it?
Yes, sir. Yes, sir.
Your name is Daniel, no?
Yes, sir.
There are 2 people were there, Daniel and Sukumaran, no? Who is the other person? Or the host? Ravi Kumar. Ravi Kumar. Okay. So one of you could help me with the chat, following the chat, because the chat seems to disappear very fast.
Yes.
So if you have, so I had asked a question. What were the various studies you have done? Then about 18 responses I had at that time when I started analyzing. I have now 31 responses, but I'm sorry I could not put in the late responses. So what are the studies you are doing? So quite a number of studies on medical education, probably we've been harping so much, Mahalakshmi, me, Dr. Sethuraman and all, that you look at medical education as a good thing for research. So quite a number of people have gone into stress and medical teachers, online teaching. So a ripe ground for research. Somebody has done on menstrual health, water and sanitation, metabolic syndrome, and so on. And if you take the study designs, mostly they are cross-sectional studies and one RCTA. And I found that actually there was a mismatch in the study design and what was being studied. So we'll leave it. And at least one response was they have not done any, or they have nothing, no study at present. So this is basically what has been done. So my challenge to you is, can we expand the scope? Are there other ways of doing research? So let me share some examples. Some are studies. Some I'll start with my my PhD candidate, Dr. Nayak, and he'll be telling. So we'll be talking of research opportunities in developing national health information infrastructure. So how do I get the data? So if I look at the data, first of all, for any research, we need data. So it is the first thing we think of is primary data. I shall collect the data by a cross-sectional study. But then there's now a wealth of data which is available. And the first one is the personal health info, non-shared personal info, self-care trackers, audit logs. So much data is being generated. And now with the advent of self-monitoring devices, this data is becoming huge. And you know what is happening now in the current today. I read MasterCard has been, they have put screws on MasterCard because they are not hosting the data here. WhatsApp and others, Twitter, all of them are facing this because of this, that they are not keeping the data inside India. Data, mind you, is a major source of not only problem, but is also a good source for us for research. And I'll show you how. The other, which is of major interest, is the clinical health info, providers notes, clinical orders, then linked investigations, and so on. And ideally, we should have what are called decision support programs, which are coming into play, helping us clinical practice guidelines, which are added on to systems, so that you're able to look at the profile of the patient and helps you take a decision on what could be the possible diagnosis or what could be the treatment lines and so on. The third element of the data cycle is the public health info. Not only the infrastructure data, but planning policy documents. But the two others is the health data and the surveillance systems. Now there are interfaces to this data. And what are the interfaces? It is the patient ID. The patient ID here, personal health. In fact, Government of India has come out with a health card. You might be aware of that. There are issues to that. So the patient will have his health information and can share it to any insurance agency or to the hospital. But the common thing is the patient ID and the health history. This is shared by health insurance. So you can have consent forms, medication alerts. If the person is already, if you have a health card and is taking some medication, a clinical, and when you go to the hospital, there can be medication alert. So the person is already taking and we have a drug interaction. So many possibilities are there. All this, when you have data, there's a potential for research. That's what I'm trying to imply. On the interface between clinical health and public health, then there are several others. So for example, the vital statistics, the health of the population, health risks of the population, what communicable diseases are occurring, and we can have socioeconomic conditions and registries which bring in the population-based data. And the third one is interface between the public health and personal health info, which are inspection reports, health education material, environmental hazards, and so on. And in the center, we get the data which is then useful for all three, but then we need it as de-identified info, mandatory reporting, like in surveillance, we have to report mandatorily, and then community directories, and survey data. So this is now the data matrix which is available to us. How can we use this matrix? I'll just give you some few examples which I borrowed from other sources. For example, personal health info, we could have client participation. Now people can report, and the government of India has already done this in the health portal, so that you can have people participating and sharing information, so that about their health and illness, so that we know exactly what is happening in the population. On the clinical front, and the interface between the personal health info and the clinical is the digital health card, which is again a program of the government of India. And we have on the hospital front, we have e-health programs, platforms are there with physician participation sites. You can interact and bring in a lot of info into the use data and give back to the community through the form of these e-health portals. Now, all these are very have potential for in our field, and if on any of these, it should be construed as an advancement of science, and not just that you have done one small cross-sectional study, some opinion of sort. These are areas, potential areas, where, because there are a lot of data available, and how do you utilize them, make them useful? I'll show some examples as we go along. During COVID times, there have been people, this war room, they have identified the communities for health. They have war rooms, volunteers have come in, and they have identified oxygen beds. All that has been of availability of data and data sharing platforms. And of course, now it is, since the IT people were working from home, many of them stepped in, and like the Sensex, they were tracking COVID and the COVID maps. So that has been a major jump in how data is being handled. If we had used this, a lot of potential people have used COVID data to enhance their research also. And in the future lies in what is called the augmented reality, wherein you can actually visualize many things. So user augmented reality would be one of the developing areas for research. So one of the major dilemmas in the field of health is that of counts and ratios versus rates. Health service data, hospital data yields counts. At best, you can calculate a proportion. For example, number of patients who came into the hospital with a particular condition divided by the total number of hospital patients. It's a proportion. Just the numbers itself mean very little. Mahalakshmi was working in a pediatric surgery. The pediatric surgery numbers were high. She leaves from there. There's a drop in number of pediatric cases. So then suddenly you find that pediatric surgery cases services are very, very low. Why? Because it depends on the services offered. So numbers can give erroneous results. So is that hospital not giving any pediatric surgery cases, or the number of people who are coming for immunization, number of deliveries in that hospital is just numbers. Whereas population-based information requires it needs a denominator of population and subpopulation data. So here I have a question: are counts of no value? So, and how do we get population data, and what are the issues? So anybody would respond? Are counts of no value? Yes, no, something? You're free to speak. Counts can help determine trends. Very good. Any other opinion? Okay. That's exactly what I wanted to show. counts can show trends. One more I have. They play a vital role. Yes, if can be more specific, they can be used to determine epidemics and pandemics. Sure, Dr. Vishnu Bhatt. And useful. Counts are data. Yes, they are data. So even pure counts are very, very useful, and they help in policy decisions. As somebody said, yes, it is a very important thing for policy decision. But there are some challenges. First of all, I'll show you how counts are useful to us. So here I have a recent, we had counts from Kerala. Kerala is putting it on the website. The number of dengue cases on a weekly basis, on a daily basis, they're putting the number of cases up. So what we did, we took this, they are in the public domain, and they are available for over 11 years. From I think 2009 onwards to 2018, when we did this study, we found that the number of cases, dengue cases were there. We actually would use this data more for learning certain statistical methods, and we found that this data is very useful. When we plotted this, as usual, we said, like Dr. Vishnu Bhatt said, you can identify the trend. Yes, it shows the trend. It shows the trend between 17 and 18. It shows two peaks, and this is a classical pattern in May, and see, every year it is in April, May. In 17, it's a big peak, and this is expected in any dengue epidemic where you have one peak and then there's two smaller peaks, a cyclical trend. So classical one, we have done further analysis. I'm not sharing that, but we had a surprise in that when we looked at the data a little further, when we zoomed into the data, and we found that when we went into a weekly pattern, the whole thing went for a toss. There was no pattern. Yes, there was a pattern, that there was a general declining trend. Mind you, these are only numbers, and they were posted on the website. So we had to be able to pull it out, convert it, bring it into Excel to be able to visualize it, or to visualize it. That process was a challenge in itself. Whereas the administrators, all it needed was an Excel sheet and a visualization, a graph, and a lot of valuable information was available. When we looked at the expanded data, that when we zoomed in and brought it on a weekly basis, we found this very peculiar pattern. You go up, go down, go up, down, and then it slowly flattens. So overall trend is fine, it is just falling down. You are talking of trend. Why is this sawtooth appearance? Any guesses? We were at a fix as to how to interpret this data. No epidemiology books show this data. Yes, this is epidemic pattern shows as a seasonal trend and a cyclical trend, both can be seen here, but this one is not described in any epidemiology book. I missed the chat. I may have to open the chat page. Data capture not standardized. Any other? Reporting errors, can there be some problem with data collection? Yes, there's a problem with data collection. Yes, there is a problem due to time frame. What did that mean? Swanand, what exactly did you mean by time frame? Somebody got it. Mahalakshmi, you have to give Saikat a prize. Saikat Kumar Day. He got the answer. Reporting on weekdays and holidays varies. Each of the troughs were very sharp. Very good. So these were the points, and each of the troughs were actually a Sunday, and in between there was one which was actually a public holiday. So what is happening in this trend is that on a Saturday, Sunday, there's a drop, it's very low, and then it builds up over the week, it builds up by Wednesday, and then it tapers off. And not a very good thing for surveillance. Reducing the time frame of data collection will give more variation. No, we can't reduce it to less than a day. The problem, what we need is that we have a look. So the fever clinics, especially when there's a epidemic going on should be functional even on Saturdays, on the weekends and holidays. And there has to be a mechanism of reporting them. Then we'll get a true picture. Otherwise, we get a distorted picture like this. Let me hand over to now Dr. Shiva, who has worked with some secondary data sources and how he has used for validation and conversion. Can we share simultaneously, or I have to stop sharing?
Sir,
You can't share simultaneously, sir. You
Okay,
want Dr. Shiva, I'll make him the presenter.
Yeah, I'll stop sharing. I'll come back.
He can start sharing.
Shiva?
sir, you are muted, sir. You can unmute yourself.
Shiva is muted.
Yes.
You're having difficulty, Shiva?
No, sir. It is showing the PowerPoint and Explorer separately.
Sir, click PowerPoint. Use PowerPoint
Can't
application.
share in this.
Yeah.
Yes.
Yes, sir. Now it's
Yes, sir. I shared the screen. So,
Yeah, but your PowerPoint has not come up. Yes.
Yeah.
yes. Yes, sir. I started the presentation now.
Can you make it full screen?
Yes.
Yeah.
Good afternoon. Good afternoon, sir. And I am doing PhD at with the secondary data mainly using and I am studying the assessment of health profile. That is the capital region of the Andhra Pradesh, mainly with the help of the secondary data that is available in the public domain. So I am using the public domain data and converting the data into the indicators, and finally we are calculating the health inequities in that area. So for that purpose, first I collected the data from the different sources. So first I collected the different sources of the health data and collected the data. And later this data was converted into the indicators. And these indicators were validated next. So whether this indicators data can be used for the study purpose or not, whether it has any deviations or whether it has any data errors, whether we can use this data for the assessment of health profile or not. For that purpose, we validated the data. And finally, a combined composite index was created by amalgamating all these indicators. So this final index is used for assessment of the health profile in the Amaravati capital region. And so for that purpose, I searched for the data from different sources and listed different sources of health data. These are the different sources of the health data that are available in the public domain. So the most common and feasible public data is NRHM HMA standard reports. That is Health Management Information System standard reports. Each and every PHC and subcenter are submitting the reports every month to this, and we can download this data on the monthly basis and for the annual basis also. And the next one is the data that is available in the Ministry of Health and Family Welfare website. And the disease alerts that are present in the IDSP reports and weekly outbreak reports, we can download them. And the dengue fever data is actually downloaded these IDSP reports from the DHS Kerala website. And next one is the CGHS dashboards and charts. They are also providing some excellent public health data freely in the public domain. And some new websites, web portals are coming only for the particular one program. One of them is the Anemia Mukta Bharat or Nexai portal like this. But sometimes we need some login and credentials for downloading these reports. And sometimes some websites are providing without any credentials. And the TBC India also providing the reports, but they are not providing the individual based reports. They are providing the consolidated reports. And AIDS control reports, National AIDS Control Organization, RANCO reports. And apart from all these, each and every state is also having their own health department websites. So these websites are also providing excellent public health data in the public domain. But these health data sources are providing the numbers only. So this much number of fever cases, this much number of antenatal registrations, and these are the diabetes cases like this. But for converting these data, these numbers into the indicators, we need some denominator. Otherwise, we cannot calculate the indicators. So for that purpose, we should collect the denominator data, that is population-based data. So for that, we can collect the data from the census 2011. And we can, it is given the village level data also for denominators, and chief minister dashboards for the different states are also there. So they are providing the mainly they not, but at the same time they are also providing the different denominators that are useful for the public health data. And the next one is the geographical details of the administrative boundaries and weather reports, pollution control board reports like this. So these are the different sources of the health data. And these are the list of the 20 web portals that are submitting the reports in the PHC every month. So in a different time periods, but not in the single day, but different time periods. And from these different data sources, and we collected the data and analyzed the data. In this process, we identified some problems in the usage of the secondary data. So they can be categorized into 3 ways. That is the problem in collection of data and problem in collected data. And the next problem conversion of the data. So in the collection of data, anonymization, that is the that is the data. Some data may have names, so we have to anonymize that. And the next one is the continuity of available data. That means some reports may give sometimes, but they abruptly stop giving the reports. That is the continuity of the available data is also important. And availability of the health data at micro level. Most of the health data is available at the sub-district level, NRHM, HMS reports also. But these reports are not available in the village level. So that is another problem. And permissions and ethics for using this data. Yes, some departments may allow to use the data available in the public domain, but some departments may not give permission. So for that purpose, we have to check the policies, ethics or permission policies, and apply for permission now. And the next one is the problems in the collected data. So yes, we collected the data from the different sources, but there may be some missing data in those reports. Some values may not be entered. That is the missing data, and the entered data may be have errors. That is whether it may be very low values or very high values, or like this the data errors. Instead of 10, they may enter 100, or they may enter 110 like this. So the data errors. These data errors may also lead to the outliers in this data. And the third one is the conversion of the data. Yes, we had the data, but to convert this data to indicators, first we have to choose the appropriate denominator. So if whether these incidents of the any fever case or anything, whether you have to calculate for 1,000 population or for 1 lakh population, it is we have to standardize the formula, and we have to choose the appropriate denominator. And whether if you want to discuss about the diabetes, we have to choose the population the middle age or above the middle age only. we should not include the children in the while discussing about the diabetes. So appropriate denominator is also important for converting the data into indicators, and non-availability of the numerator and denominator in the single source. Yes, we already saw different sources of the health data. Some are giving the numerator data and some are giving the denominator data. So these are not available in a single source. So we have to collect the data from different sources and combine them to create an indicator. Yes, there are many data sources available in the public domain. So which one to choose? That is the common question, whether we can choose the any public domain data or not. So the data source which is reliable, valid, and regularly collecting data from the ground level and giving reports continuously should be selected. That is the opinion given by the World Health Organization while choosing the public health survey data in Urban Heart Manual. So most of the times we can depend upon the HMIS data, that is a reliable source and valid, and they collect the data every month and give the reports continuously. And IDSP reports is also one of the reliable source. So how to solve these issues? So what are the different techniques we can solve? So by visualizing these indicators into the different plots and box plots or bar diagrams, we can solve these issues. So here we are showing one example, that is the box plot of the proportion of pregnant women registered for the antenatal care. So we can see generally we will expect the proportion values within 100, but here we are seeing the values above 400 also. 400, 300, and 200. All these proportions are completely implausible. We cannot expect them. So it is showing that the values are definitely outliers, and all the sub-districts are not showing those outliers. Only few. The Rapella is continuously showing an outlier. So we have to find out the reason why the outlier occurs in these areas. So presence of outliers in the data, it highlights the errors in the collected data. So we have to clean the data. So how we have to clean this data? If it is the outliers are there, how we can clean? First, we used the technique of using the averages of the remaining sub-districts. For example, in our study setting, there are 20 sub-districts, 10 are in the Guntur district and 10 are in the Krishna district. So if it is the outlier data is in the Guntur district, then we will use the average of the remaining sub-districts in the Guntur district. If the outlier sub-district is in the Krishna district, then we will use the average of the remaining sub-districts in the Krishna district. So in this way, we can correct the techniques, and apart from this, there are so many other techniques also there. But it is one of the technique for data correction. And the next one is the calculation, the problems in the calculation of the indices. So already Sir told about the importance of the numbers and indicators. So 30 infant deaths in a district will not convey any message. So, but we can, if you add the denominator, 30 infant per 1,000 laborers in a district in a year, will tell about the health status of the children in that particular district. Just the number will not convey any message. Okay, so the just numbers in these reports will not convey any information, and these numbers should be converted into the indicators using the standard formula. So for converting the indicators, we have to use the standard formulas that are universally acceptable. And for example, if we want to calculate the infant mortality rate, we have to calculate it with the 1,000 live births. For example, the other reports may have also comparable. We can compare the findings with the other reports. Otherwise, if you calculate the IMR with 100 live births or 1 lakh or 10 lakh live births, they are not comparable. So we should use the standard formulas. And sometimes the numerator and denominator will come from the different reports. So we have to aggregate these two reports in one single Excel sheet or anything. That is the and we have to calculate these indicators. And denominator should be carefully selected for the reports. For example, if it is a vaccine preventable disease, we should use the denominator, the children, under 5 children years age group only. We should not include the adult population while calculating the incidence or prevalence of vaccine preventable diseases. Like this, we have to choose the appropriate denominator. So, so these are the different problems we can encounter while calculating, we're converting the data into the indicators. So here I'm showing the 3 examples, the both numerator and denominator within the HMIS data, and so proportion of registered pregnant women having anemia. This is an indicator, and the numerator is the number of women with the anemia, and number of pregnant women registered for the antenatal care, that is the denominator. The source of these two, numerator and denominator, will come from the HMS data only. There is no need to search for the another database. But here, in this example, incidence of dengue fever, the numerator is the number of dengue fever cases. But here the population is the denominator. So in this setting, you have to use the check the denominator data from the different source. That is the census data. We have to collect the denominator from the different source. And the third one is the both numerator and denominator from the other than health departments. So, for example, nutritional status indicators, they are also considered as a health related indicators. So, proportion of severely malnourished under 5 children. So, the numerator under 5 children suffering with the severe malnutrition, and the denominator is the total number of under 5 children. So, the numerator and denominator, numerator will come from the ICDS reports, and the denominator will come from the census reports. So, like we have to check the source of the data based on our required indicators, and we have to aggregate the data, and we have to convert data into the indicators. So, what is the use of the conversion of the data to the indicators? So, the main purpose of the conversion of the data to the indicators is to convert the data into the useful information. So here we converted the data of dengue fever cases in the Kerala state, and calculated the incidence of dengue fever cases per 1 lakh population, and for the year 2011 to 16. So these are the this is the animation image showing the incidence of dengue fever cases, yearly incidence. And we can observe how the incidence spread in different districts in the Kerala state. And this is the picture showing the weekly incidence. And this weekly incidence of dengue fever cases depicts the spreading pattern of the epidemic in Kerala. So we can here we can observe how the this from May to the October, how the dengue fever incidence raised in different districts within the Kerala, and how these raised incidence was gradually decreased, and what is the pattern of spreading of the epidemic of dengue fever in the Kerala. This weekly incidence map showed excellently. And now I want to share that is another Excel sheet, that is the dynamic pie charts. So
stop point and show Excel.
Sir?
I think we'll skip it. We'll show if we have time. We'll because okay, show it. Please show it.
Okay.
This is for visualization of data. Just show. Oh.
Yes, sir. This is for the visualization of the data, and it's an interactive pie chart, and we can select the indicators here, cesarean sections and deliveries. So based on the selection of the indicators, the pie charts from 14 to 18 will change, and we can also select the sub-district within our 1 or 2 sub-districts like this to highlight our the the pie charts. So these are the scroll and zoom charts to show. These can be used to depict the incidence of dengue fever cases, and continuously this.
This data is over 15 years, so it cannot be seen in one graph. So therefore, you zoom or scroll, then you'll be able to see the data.
Yes. Here you can see the data from October to 2009 to October 2000. And like this, we can from October 2010 to October 2011. By in this way, we can scroll the data from 1 year to the another year continuously. And this is the scroll and zoom chart. So here you can the zoom in and zoom out the data within the year also. Okay, by we can scroll to the next years, and also zoom in and zoom out these years. And so in this way we can use the different dynamic charts and interactive charts to depict and visualize the data. Thank you, sir.
Thank you, Dr. Shiva. Basically, what Dr. Shiva was trying to convey is that there's a lot of data available outside, and in fact, he's done his PhD work just based on secondary data and not on primary data. And it is a question of how you look at it. So therefore, in this, of course, there are some ethical issues and other data challenges. There are some ethical issues because you cannot go down to individual level because of privacy issues. That has been a major issue when we go to public health research. But there's plenty of data available for our research work. It is a question of, there are some challenges by way of data, faulty data, but there are ways of correcting them. But one important point which you mentioned is that any data, even if you're collecting research data, there would be missing data, and there are methods by which you correct it. You cannot whitewash the data. I think that's an important learning point when you're conducting research. So let me get back to my presentation.
Sir, before can
yes,
we take
any question?
We can take some couple of questions, sir, from chat box.
Oh yes, please. Please.
Vishnu Bhatt, sir, our Director of Medical Research, has asked a question. When the denominator is not available, is there any method for analyzing the data?
Shiva, you want to answer that?
Sorry, your voice is
It's got a voice, I think, a connectivity problem. I'll answer that question. Shiva, you want to answer that?
Yes, sir. If the denominator is not available, we can, that means we can use the data for the trend purpose, for the different purposes, but not for calculating the proportions or ratios.
That is one. But the census, of course, 2021 census is due. But if you can use the census give population level information up to the village level. So if you have the village or the location data, even broad location data for any hospital-based data, or for any data for that matter, if you have the location, you can draw the denominator from the population from the census. And that's what Dr. Shiva Nayak has done. He has taken the census. Of course, the problem is census is only once in 10 years. So therefore, you have to do some adjustments with the census by using the growth rate so that you have a better understanding, a better denominator. But census is a very good denominator source. But then there are many other databases which are available at the district level or even sub-district, going even up to the village level. Census actually gives a large volume of information right up to the village level, education, housing, so many things are available. So that's a point he was trying to make. Any other questions?
So the second question is from our Dean HP, madam. Where do we start if we want to use in public health domain? Are there any special training programs? And the continuum of the question is, do you need to be a public health expert to do this sort of research?
Of course, you start with my MD community medicine. No, not true. Anybody can do. Shiva, what all training did you undergo for your work?
So
You're muted.
not audible.
He's muted.
So you're not audible.
Yes, sir. I undergo different I attended workshops and trainings for conducting and learning the techniques for usage of the different statistical techniques. But many of them we can learn in the website in the internet only, madam. But the Coursera websites and YouTubes, they are also providing the excellent tutorials for learning the different statistical techniques. And the only need is if you want to certificate, then we can attend the programs.
We don't want
Two main things
certificate.
that
We
he
want to
said.
learn.
He was required to learn R programming. So he learned R on the two courses on the net. And the other one, which is used for those maps, is called QGIS. QGIS is an open source software. Again, of course, both of us went for a course in local in Pondicherry, an organization called Feral for the initial starting, but then much of it he learned by himself using the variety of coaching material available online. There are several courses available, simple to complex. So I think in today's world, it's very easy to learn the skills required for any analysis, including he did a very complex analysis. We found out of comparison of maps. Very few people have done that. And we found the software for that, and we could implement it. I'll show you some more examples as we go along. So that's to
So, like,
answer
why I
Mahanik's
asked this
question.
question, no, sir,
Yes.
is mainly because with this COVID, now that we are sitting on a vast amount of data in the sense with regard to
Correct.
COVID vaccination or COVID, how it has affected the community or death rate in COVID. Any of this you take, I think this data is available in public domain. Suppose
Yes.
we want to try to understand what has happened or try to find out answers to many of these questions from the community. So where do we start? Like that was my intent of asking that question. Maybe you'll answer that during the course of talk.
Yeah, I'll give some examples, but basically you have to get first of all, the data, access to the data. It may be your own data, but try to get the denominated data from other sources. And as far as statistical techniques are concerned, you have to look at what you want to do and then find chi-squared is not the end all for all analysis. So you can do much more sophisticated analysis, which is available to you, and there are many groups which will give you the answer. Much of what Dr. Shivanayak has learned is by posting in ResearchGate and having discussions. It's a little effort. But if you want to do the whole analysis in 3 days, because I'm appearing for the interview tomorrow or next week for assistant professorship, then I think that's not feasible.
Sir, one more question.
Yes.
Continuation of denominator question from our but sir. Like when you're using secondary data for analysis, do we have to do any indirect or direct standardization?
Yeah, that's what saying that first of all you have to look at the data, find out what is missing. That is a type of standardization. You look for outliers, and then you have to take a decision on the outliers. He showed you some graphs. Those are box and whisker plots. There are some things which are obviously not correct. You cannot have a 400% anemia among. No, it's not possible. You cannot exceed 100%. So those you have to eliminate. And then what you do with that missing part. So you have to either fill it in, because the more you remove, then your other analysis is vitiated. So you have to be very careful. These are very important decisions to be taken during data analysis. And you have to be very clear that this is my methodology. Then you're following scientific principles. You just fudge it out, and that's not good statistical, that does not follow statistical principles. In fact, if you look at good journals, will ask you, what is the missing data? How did you handle it? All those questions have to be answered. And a very important one is also, what is the response rate? I'll be touching on that shortly. Right. Any others?
Sir, we'll proceed with the presentation.
Yeah, because otherwise we'll be running short of time. So let me go on. We'll go to some studies which I asked, and I'll show you some studies, some queries I also raised. And the first one, I asked you a question, participants a question. Patients complain that they have to, in fact, this was a question I found in one of the corporate hospitals here. Patients complain that they have to wait a long time in the hospital. So I asked the question, how do you identify the bottlenecks? How will you design the study? So as usual, we had somebody was very frank. He said, I don't know. And most of them said they will do a cross-sectional study, descriptive study, utilization of services, and so on. Some are not. One person said no idea. Unfortunately, word cloud has a tendency to break the words. Actually, it's cross-sectional study. I did not know how to solve this. Mahalakshmi has to teach me that, I think. Okay, where you have, even if I put the words in quotes, it still breaks it. So one person said that it is what is called a time motion study. In fact, we did a time motion study way back in the 80s in JIPMA. We followed patients and tried to find out what happens. A person joins the queue at 7:30 in the morning to register. He gets registered at 10 o'clock. Then he goes to the outpatients, waits there till 1 o'clock. And then he meets a doctor at somewhere around 1 o'clock. And within 2 minutes flat, is seen and then sent off. And he goes again to the pharmacy and stands for a 1-minute consultation. He has spent a lot of time. We tried to, the idea was to improve that, but it didn't work. A similar problem I had in another corporate hospital. So then I was again wanting to do a time motion study. But I thought, why? There are timestamps across the hospital, and then I found that that there has been a study in the UK. So if you go to a corporate hospital, from entry to exit, there are several timestamps are there. When you register, when he goes to the what is called the investigation counter, when he meets a doctor, everywhere there's a timestamp. And if you get hold of the timestamp, you have a huge volume of data which you can analyze. And that's what has been done in the US, UK, with the NHS. So what they did the patient flow network for accident and emergency of UK hospitals. Because why they wanted to do? Because that is a key determinant of efficient hospital functioning. And they have now that all the hospitals here have got NAC accreditation, there are several criteria which they had to, matrices which they had to meet. And so in UK and in A&E, there's a 4-hour waiting time. That is a target metric. So they wanted to analyze whether the hospital is meeting that way or not, the matrices or not. So studies focused on the linear flow process, queuing and single patient pathways. And they viewed the hospital as a network of connected patients which are transferred between the accident and emergency and to various departments. They used a technique, what is called graph and cluster analysis, to identify patterns of patient flow associated with the good and poor accident and emergency performance. And there's cyclical patterns of patient flow. That is back and forth. Does a patient go to a center, then come back to another center, go to another point and come back? So this is the graph and cluster. In fact, if you say graph analysis, you'll find a very good quiz on the net, which is a bridge problem. How do you cross? There are 7 bridges in a city, and how do you get across the 7 bridges without even by crossing the bridge only once? So that is called graph analysis. And the software is an Excel software which is available, Node Excel. It is free software available. If somebody is interested in doing the study, it will be very interesting for a hospital administration, for hospital efficiency. It will be very interesting. So what did they find? So they drew this graph. This is what is a graph. Actually, these are supposed to be two-way arrows, I mean directional arrows, but they have ignored the direction of flow. I'll explain this. So the dots are what are called nodes, and the nodes are, these green dots are for one hospital of the NHS, and the wards of each dot is a ward or a service point of the NHS, and the blue ones of another hospital, and which together form the King's Hospital which is a major hospital in United Kingdom, and there are some other dots which are external to the King's Hospital. The dots are called nodes, and the lines are called what are called edges. The edge, and the thickness of the edge represents the data flow between any 2 points. And these two big dots from where everything emanates is called the accident and emergency. These are the points, and from there you can visualize what is the type of patient flow. That was the original problem, isn't it? So I'm sorry. Original problem. So here you can find out what is the direction of flow, what is the delay, and so on. So this is a very challenging type of analysis, which you don't have, there's no interaction with any patient. So, but yet there were some challenges, and from there they could then draw that where the maximum traffic occurs and what could be the delays. So this is two examples. Patient flow, previous day, patient flow, same day. A lot of sub-analysis could be done per hospital. This is for one hospital and this is for the other hospital. So they could find out that maximum flow was between the accident and emergency and the surgical departments. If you do an analysis in Mahatma Gandhi, you may find that it is actually between A&D and the gynecology department, because they conduct so many deliveries. So like this, several things which can be done here. Then there are the red zones, then the green zones are the positive, the red zones are the negative. So a lot of sub-analysis could be done. They could also find out what is the time lag, and whether what was the relationship between the high case load, low case load, and so on. And they really did not find much of a difference based on, there was difference, but it did not affect the quality of work. So like this, there's a lot of scope for looking at data which is just lying there and taking, not only doing your research, but also a lot of administrative issues can be solved by this. Something which then NABH would be very happy if somebody does an analysis like this. You are not able to see my screen?
It's visible, sir.
Oh, we are able to see. I think maybe
somebody will say. Okay. Yet they had some problems, which was the first problem was that no patient could be, patient data could be given. Patient identification was paramount. Not only they did not want to identify the patient, they did not want even by a secondary means identification of the patient. So if you given a given date, a transfer, then somebody can backtrack and found out which patient or which service was a problem. So for that, what they had to do, they removed all the patient identification. They even have to remove the event identification, the issue of ethics. You may think, what is this? I'm just analyzing data. But if you look closely, then the issues can crop up. So what they did, even if you don't want to identify an event, for example, one transfer between A and D, which was delayed, you can backtrack and find out why that person, who was the person behind it, and it can have negative effects. So therefore, what they did, they aggregated the transfer data on a weekly basis so that the investigators just could not find out to either the patient or to the event which was causing the delay. So like this, even you have to take care of several elements when you want to do, when you plan a research, and you have to be very careful on some ethical issues. I had asked another question. Any questions on this? This is published. I have given the article there. It is in acute care hospital. It is accessible. The article is accessible in the public domain. And asked a question on TB notification. I'll give a hypothetical case, and how do you, what type of study will you do when you have two strategies for promoting TB case notification. Notification is a very important element in not only for tuberculosis, but of many other diseases, including now for COVID. So I had asked, what study design would you like to adopt, and is it ethical to notify the cases to health authorities? Please give your reason. So I'll take the second one first and look at the ethics of notification. Why I asked this question was the National Strategic Plan for Tuberculosis. It is developing a plan where they are going to give incentives to doctors for first notification and then ensuring completion of treatment. It's quite a substantial amount. So to bring in the private practitioners, other doctors into the mainstream of TB care, because TB has become such an important disease now, especially with all sorts of resistance which is coming in. So therefore, multi-drug, single drug, so many problems are there. So we have an issue. So, and the basic strategy for overcoming the resistance is a good treatment schedule. So that's how I thought about this. And let's look at the ethics of notification. So all of you gave that it is later somebody added he was not very sure, but the reasons for why it is eligible for notification, and you also gave several reasons. For example, it is data for greater good. It's ethical because it's for public welfare. It helps government to have data, reduce caseload. Health authorities have responsibility. And the other side is duty of the healthcare provider. Cases need to be notified to health authorities. Notifications will help. So several reasons here given. It will help health authority to upgrade the data. Ethical clearance is must. So that was just a statement. Randomly allocate. Okay, leave it that. So if I have to give labels to these, the ethical principles behind them, this is utilitarian. What you do for the general good of people. Mind you, if you are doing any study, these are the principles which you will be asked. What principle are you following? Then, for ethics of research, you please refer to the Nuremberg, not Nuremberg Code. Now we have the WMA. I'm sorry, it's slipping my mind. First of all, ICMR guidelines for ethical research, and all these principles will be outlined there. So it's one is utilitarian. Second is fiduciary. Fiduciary means duty bound. You're duty bound to do this as a doctor. You have to provide the health. It's a duty of healthcare provider. So that's the second principle of basic principle of healthcare. And you also want to maximize the benefits for the people. And you also talk of the research ethics. These are the basic principles of ethics. And there are some add-ons in when you talk of research ethics. I'm not going into the details because I'm not focusing on that. I'm just giving an overview. Research ethics itself is a 2-hour workshop. So maybe we'll handle it some other time. So what's the problem of surveillance? Surveillance, the disease surveillance is a basic public health activity, and it is very important for epidemic control. I'm sure all of you from the third year, you would have been drilled by the community medicine department on this surveillance. So let's not get too much into that. But one of the important points and ethical issue comes out of that is it is to reduce inequalities, because pockets of suffering may be there which are unfair, unjust, and preventable, which cannot be addressed unless they are first made visible. So surveillance, which is often misconstrued because it is equivalent to spying, as a very important activity, not only for control of disease, but also to identify pockets which may be of inequalities. So this brings in the principle of justice and equality. This is the definition of surveillance. I will skip over that. But what happens? The dilemma is that it may limit privacy, but also civil liberties. And thus we have seen in this, because everybody is fighting over what is happening in COVID-19. Why should I, in fact, there have been clashes. It may trigger mandatory quarantine. In fact, we have seen all these points in this particular epidemic. Mandatory quarantine. Today in the papers, I found one community has been completely locked down for several years because somebody or the other, they come into the 14-day cycle, then somebody else becomes positive. Then they were quarantined for the next 14 days, then one more person becomes positive. So they have been isolated for several days now. So a mandatory quarantine isolation, it creates a big social problem. There can be seizure of property. Then if you are name-based, because often you have to name the person, that has its own issues, and you can have discrimination and stigmatization and seriously harm people. And we have seen this also in the initial part of the epidemic, mob reaction. And now again, it is on the flip side, we have got what is called revenge tourism. New coins are coming up. And it is compounded when there's a lack of trust on the powers that be, whether the system will keep their name secure or use it for putting in jail, say, or sedition laws. So that's the fear, and that's why the problem. And also the fear is whether they will release your personal data or they will give aggregated data. You think that they should give only aggregated data and not individual data. So these are several issues and this is the first thing when you go for when you go and ask for data, people are going to ask you, what will you do with the data? Why do you want the data? Government, especially government sector, is very, very wary of that. Some of my colleagues wanted to do data on tuberculosis. They say, yes, we can give you the data, but I'm sorry, I'm not giving you the data. So many of their work has fallen flat because of this issue. Based on this, the experience of SARS, what has happened in the recent past? There has been an expansion, especially after SARS 2003. The WHO expanded what is called the International Health Regulations in 2005. The revised regulations gives more flexibility to target, because initially it was a very small list of communicable diseases. But now they have expanded the thing for public health emergency of international concern. COVID is one example. And it establishes an obligation to create the core capacity for surveillance and outbreak response. So core capacity for surveillance and outbreak response for public health events. But what has happened is, as of November 2014, 48 countries have not yet communicated and 81 countries have sought extensions. More than half of the world are not geared up to this. That is an issue when suddenly you're hit with a pandemic like COVID. So here what happens is the critical challenges in public health, there's a push and pull. And the thing is, on the one side is the principles of which goes towards the community and therefore supported by the government. The other side is individual, which is supported by the society. Do unto others what you would like to do unto you. Reciprocity, solidarity, do it as a collective. Equity, share everybody on not an equal platform, but an equitable platform, and do it for common good. Compared to, so these are cross challenges. When you push this up, this comes down. Because when you look at individual rights and look at common good, then individual rights are superseded by common good. Your privacy is taken off and your autonomy to take decision is not there. So these are some of the challenges, and we'll look at a couple of examples after this again. Now, how do we measure equity? So what data sources to use? I'll over to Dr. Shiva Nayak to just show how he has measured equity as part of his study. Shiva Nayak, please.
Yes, sir. I am sharing the screen, sir. Yes, sir. Yes, sir. So in the public health, generally we will see the words inequity and inequality, but there are two different words. So what is the main difference between the inequalities and inequities? Is the health inequities are the differences in the health status. So that is only the differences in the number of cases or proportions. They are considered as the health inequalities. But if these inequalities are socially produced and systemic differences, then they can be considered as the inequities. And these are the main characteristics of the inequities are they are avoidable. They are we can prevent them inequities by changing some modifications in the society, and they are unfair in the distribution. So because of these preventable nature, we can say that the presence of inequities can be called as the unfair in the distribution. So World Health Organization proposed one metric that is called as the Urban Health Index, and it is mainly used to measure the health inequities in the urban areas, in the different city areas within the city. And it is a standardized amalgamated index of the two sets of the indicators, the health determinants and health outcomes. By combining these two indicators, they calculated one single index, that is the Urban Health Index. So by comparing the distribution of this urban health index, we can assess the health disparities. So in our study, we used two different sets of indicators. The health outcome indicators. These are the 10 health outcome indicators we used to assess the health inequities within the Amravati city, and causes of cause-specific proportional mortality rates of accidents and suicides, and TB cases, mortality rate, infant mortality rates, and cardiac patients, and healthcare service deliveries, and secondary sex ratios, and under 5 mortality rates like this. And we combined them with the health determinant indicators. We used 11 health determinant indicators. That is the proportion of SC/ST population, female literacy, and marginal workers, and no access to the safe water, and the housing conditions, and PHC population ratios, and the people without LPG. Like this, we combined the health outcome indicators and health determinant indicators. So a total of 21 indicators were used in our study, and we standardized them using the formula that is proposed by the World Health Organization Focus Center. And after standardizing these indicators, we calculated the composite index by combining the geometric mean of all the standardized indicators. So this index is the overall value of the one particular geographical unit that depicts the health status of that particular area. So by calculating the urban health index for 20 sub-districts in the Amravati capital region from 2014 to 2018, and we combined these UHI values to the shapefile of the Amravati and created these choropleth maps. So in this maps, we can show the differences in the health inequities. The low values, that is, have the areas having the better health profile, and the red colored areas, those which are had the high UHI values, and they are the poor health, having the poor health profile. So the differences, the ratio of high to low, these are called as the health disparities, and they are ranged in between 5.01 to 7.86 in the years 2014 to 18. But here in this map, we can observe that there is a sudden change from one color to the another color in the political bound, according to the political boundaries. But this will not occur in the reality. So the health index or health indicators will not change according to the political boundaries. So for that purpose, we created the interpolated maps using the same values using the inverse data weighting technique in the spatial analysis technique. So based on that, we can convert the choropleth map into the heat maps, and we can predict the indicator values for each 1 square kilometer. So here these maps are showing the interpolated values in the Amravati capital region, and we can observe that there is a gradual transition of the values. The white colored areas are having the low UHA values, having better health profile, and red color, dark red color, are having the high UHA values, having the poor health profile. So we can observe the gradual transition in between these areas. So like this, we can use the public health data and assess the health inequities and can check whether these health inequities existed in the area, how far they are existed. So based on these inequities, we can assess the availability of the healthcare centers and accessibility of the healthcare centers. And like this, if you want to propose to establish new healthcare centers, we can propose them to establish them, or we can use suggest different suggestions to reduce these health disparities. Thank you, sir.
Thank you, Dr. Shiva. What is trying to several new techniques are available. In fact, this technique which you have shown here has been extensively used for making policy decision for AIDS, the interpolation technique. Ethiopia has used, many countries are using these techniques. Any questions? Can you stop sharing your video, Dr. Shiva? Any questions? How much time can we?
There are 2 questions in the chat box, sir.
Yes, I'm not seeing that.
Yeah. First question is, what are the ethical issues involved
In this study?
I think it was a general question, sir. What are the ethical issues involved in maybe secondary data analysis?
Yeah, I showed that. In the ethical issues, these are some of the issues which are there. Which I just, we have to follow what is called the Helsinki Declaration. And basically, if you look at it, every time you have to look at these elements, the individual rights, privacy, are we somehow impinging on the privacy of the person or the autonomy of the person? Are you doing good or are you doing bad? I'll just come to this again when I talk of vaccines. Is that okay? So
Yes,
let
sir.
me continue and give you a couple of more examples. So we asked about study design for TB trial. And again, the participants made, most of them chose what is called a randomized control study. Then some were not really study design. So Mahalakshmi has a lot of scope for organizing more into going in the nitty-gritty of how do you make study designs. Just a simple one-day workshop will not help. We have to have smaller groups and to go into identifying what exactly study designs for each type of research question. So this is how data is collected. These are the study designs, which are very commonly used in the field of medicine. We have the observational group of studies, and then which starts from descriptive to cohort. Many of you listed as in your what studies you have done have been, most of them have fallen in this category. We need to go on the higher level. At least you go to case control and cohort, they are analytical studies. But on the experimental side, the laboratory experiments, and then we have the controlled and the highest level is the randomized control trial. Now, the issue I'm trying to make is always we need to achieve this. That's what we'll have to see. What are the issues when we come up with a new disease? What are the challenges for randomized control trials? What are the ethical issues within that? So you said, most of you said we'll do a randomized control trial, but when we go to the community level, then a pure randomized control trial does not work because of several reasons. And so we have a new another type of randomized control trial, which is called cluster randomized trial, because they use as groups of people. People have done these studies for example, when they want to do the surgery practice in a given area. So they have used, instead of just a randomized control trial, they have done a cluster randomized trial to test interventions when the decision of the policy taken is on behalf of a group. For example, when you're doing, let's say, ivermectin trial in a community, when you want to do a health education strategy in a community, or even if you want to clinical practice in the community level, do all clinicians follow a particular protocol or not? There's several examples like that. But why do you do a cluster? The biggest fear that is there is what is called the contamination, which occurs even in clinical trials, mind you, when SAKE, the authority on randomized controlled trials, if you say you should need coal-faced commitment, like people who mine coal, they are so committed, even they get dusty, they are completely black, but they will go and work at the coal face. So like that, a randomized controlled trial has got, and I will urge all researchers, anybody is interested, you should look at, and especially randomized controlled trial, if you're doing controlled trials, you should study Saket's series on randomized controlled trials. So the fear, even there, contamination occurs. Some inadvertently break the code, and the blinding goes and the bias goes off. So contamination can occur when comparisons of public health promotion interventions within the same community. So you're promoting something and you're in one way, and you want to see whether which system works, but the people talk to each other, and then the ideas get disseminated and the contamination occurs. And different approaches to healthcare provided by same clinician, I mentioned that, and lower implementation costs or administrative convenience. So then we use a randomized control trial. So what are clusters? Anything which has have a similar feature. For example, village, community, administrative area, hospitals, worksite, professionals, for example, all students taught by a specific teacher, all of them are cluster. So though many of you are doing educational research, so a cluster trial may be worthwhile, because you cannot randomize an individual within a classroom. You have to treat the whole classroom as one group, and you want to see how well a particular strategy has worked or not. So cluster randomization is an important feature which is useful for us. Shall we have a poll? Do you have time? I think I'll skip for paucity of time, but I have a question. The idea was that I'm sure that hardly anybody would have done a Swachh Bharat program. And as I said, the Swachh Bharat website has a wealth of data. In fact, this map, it's a very interactive map. Please have a look at this map. And because when I listed the initial, nobody had done something on, nobody had listed something on Swachh Bharat. So I assume that very few studies would have been done on Swachh Bharat. But this website has got a wealth of data, and these are very interactive maps. I wanted to show you live. If I click on any state, it will drill that state, and it will go down to the district. But it's numbers. But they have done a lot of, and it goes by years. What is the progress over the years? Very good way of visualizing data. Something, somebody can take this as a project for the hospital, and NAC will be very greatly impressed as to what is the distribution of, what is the case load in the hospital, what is the type of cases. Drill down. Just visualization of data is an art in itself. You don't have to do the data. You leave that work to other people, but you conceptualize this, you interpret it. That is what is a challenge for us professionals. So much analysis has been done, and you can download it from this website. There are different types, access to toilets, Swachhta Sanskriti, assessment study of impact of sustainability, health impact of Swachh Bharat. Several studies have been done, and they are available in the public domain. So there is data available to you. It's a question of how you frame a research question and how do you analyze it. And I'm sure there'll be also funding available to you. So since there's a lot of pressure on doing research, you please look around, and you may be surprised at the amount of information which is available for analysis. Now somebody I'll share you both on methodology and the subject. So somebody went around and did a randomized control cluster trial, and it was published in BMC Public Health. And I think a lot of funding also went in, and these people are of a very high standard. They are in the public health. Some of them are in leading institutes and so on. So what they did it in Gujarat. They identified several clusters to promote what is called 5-star toilet campaign. And they did an intervention Basically, it was some street place and so on. And they wanted to find out whether how effective and whether there's an improvement in the toilet usage as part of Swachh Bharat, and whether it improved or not. And they used this cluster randomized trial design. They randomized the villages. One, they did an intervention, and another they did another intervention, but was not directed at toilet usage. And what they measured was, after the study was done, they tried to find out whether the people use the toilet or not by asking them a question. Did you use the toilet last time you had to use it? Or did you go outside in the field? And to their surprise, they said the intervention failed because they found that actually between the baseline and the subsequent measure, there was a drop in so-called toilet usage. Possibly not incorrect, but that's what they found. Then but very nicely, they analyzed as to why the reasons for failure were there. And science has to be open that way. We tend to wash over whatever is negative. Now, that's not the spirit. So even though the cluster randomized the effect, they could not demonstrate. They have tried to analyze the reasons why their campaign failed, and very nicely they have done it. So they say the intervention itself was ill-conceived. It failed to reach the target audience because already the level of acceptance was high, and you should have actually addressed the people who are not using toilets rather than address everybody. And it was delivered to population who are already using toilets. And most important, the clusters were spread out, so the logistics became difficult. They could not address various socioeconomic strata. Now, these points which I'm mentioning here are issues which are there in every field. Talk of population-based dynamics, these are some of the considerations you need to have. We have encountered it every time, but for newbies who are just entering, you have not had, because now many from the clinical side also want to do population-based studies. You need to take cognizance of several factors, which are, there are several socioeconomic status. In Pondicherry, for example, the lower communities, what we call the scheduled caste, scheduled tribe communities, are totally segregated from the main village. It is called pit. 70 years after independence, we are still in that status. We may talk big things, but that's reality. And that's very obvious that and when these caste groups do not mix when you have a program. So it becomes a challenge for us when we have a program as to how do you intermingle these two caste groups. It's, for the field workers, it is really a challenge. Then there are weather conditions. Surprisingly, Tamil Nadu everywhere, this month is everywhere is raining. If you had gone to Uttarakhand, you would have been washed away. So these are many areas. So you have a program, it doesn't work. Then the livelihood of people impinges on certain the way you can conduct the program. And there are social issues. Women cannot participate in events. So these people, nobody would come in the afternoon. Who will come? They will rather have their lunch and have a sleep. And if you have it in the evening, if we have in the evening, women cannot participate because there are social taboos. And in the evening, neither can the men, and especially in Tamil Nadu.
Dr. Shambhu, please mute yourself. On Dr. Shambhu.
I muted him.
Okay. Thanks.
Okay. So thank you. And neither can men participate in these events. Why? Because of this. And especially in Tamil Nadu, you cannot go. If you'll be, in fact, you are risking your life. You want to have a event in the evening. So we have, when we come to these when field-based programs, you have to really have a lot of consideration for many of these. When we come to prevention, RCTs and prevention, then it really becomes a challenge. And why everybody talks of RCT? Because that's the ultimate. But you cannot see this small logo, Mercedes-Benz. Carl Benz said the best or nothing. So many a time I get into this problem that no, oh, this is not an RCT, so your findings are not valid. No, this is not a, you have not have a control group. Your findings are not valid. So please do not get into that mode that it is only RCT or it's not research. I have found many people getting into that trap. There are several other levels of evidence which we need to rely on. So let's look at vaccine efficacy. And the challenge has been in the current epidemic. And the challenge has been what happens when you have such a disease? What are the issues which come up? First of all, you have what are called spatiotemporal variability incidents. So where you are doing a vaccine trial may not have the problem. We need vaccine trials in India, but the vaccine trials were done somewhere else. Of course, they managed to do a lot of spread. They spread out the trials. And in fact, what was to be done in 11 years, as they have done in 11 months, but still there are many questions which are unanswered. There could be surges in infection, and it's very difficult to predict the incidence and location of cases. Where do you expect the cases to come? And you just can't anticipate. It's continuing challenge we're having in this COVID epidemic. And predictions may be limited to availability of high quality surveillance data. We know we are so suspect of itself. My wife is a better predictor of the number of cases which will come in Coimbatore, because she said every day they'll reduce by 100. So that's obviously there's some fudging of data because the politics have come into the play. So instead of the true surveillance data, we have got some cooked up data. Yet that is the data we have. And we cannot define a predefined target population. Now, the new variant, whether it will be children, whether it's elderly, we do not know. And what is the number we need to vaccine or vaccine efficacy? I'm not getting into this vaccine efficacy and all those things. That's a debate in itself. So the challenge in vaccine trial is, unlike in endemic diseases, clinical evaluation process must start early to capture transmission. There needs to be advanced planning. In fact, you need an expedited protocol and rapid staff training, quick evaluation, and we need to find out whether benefit found may be used under expanded access before licensing. That is, even before licensing, can we use? And in fact, people got confused with the Covaxin, and when the ICMR said, please use it in a clinical trial mode. So everybody became very, what is this clinical trial mode? Even doctors got confused. So, but this is what it means, that we are giving you special access even before it is fully licensed. Now, the other issue is, if vaccine is highly efficacious, what happens? The trial could contribute to the waning of disease. And once a disease wanes, then you do not know whether how efficacious the vaccine is. And therefore, not necessarily for clinical evaluation. And once the outbreak is contained, you may not have established the vaccine efficacy adequately. And should you wait for another opportunity to arise? So these are some of the dilemmas which crop up when we have such a trial. This type of thing occurred much earlier when we did the Tuskegee syphilis trial, because by withholding penicillin, they withheld because they want to study the natural history. So can we withhold? You have a highly efficacious vaccine. Do you withhold it just to study the full natural cause? These are some very sensitive issues which are there. So, so what happens when you want to do it as an RCT? Can we do a vaccine trial in an RCT? The challenge is that, can you do a controlled human infection study? How do you know that the vaccine efficacious? So they have done, in fact, they have done a controlled human infection study. Mind you, you are exposing a person to COVID, which is a very dangerous disease, Ebola or something like that. Studies involve exposing healthy participants to relatively high risk, and first in human interventions, and public trust in research is particularly crucial. Why do you need it? Because you need an accelerated vaccine development. You need to most effective candidate, you identify most effective candidate, validate test of immunity, improve knowledge of disease, and who requires it most. So what is the ethical dilemma which gets vitiated? Somebody asked me about ethical dilemma. When you do a vaccine trial, you are actually doing the non-maleficence, do no harm, because you cannot guarantee harm. And in this trial, COVID trial, you are actually doing harm by exposing the person to the disease. And the vaccine itself can cause some problems. And whereas the beneficence, whether it will protect you, you do not know that. So it is counter to what ethical principles that you normally propagate. So these are some of the issues which are there. So, why do we need placebo-controlled trials? There are many candidate vaccines. Regulators such as FDA are willing to give approval prior to completion of phase 3 trial. But the issues which crop up is when you find that it is some benefit. One of the rules of RCT is that if you find some benefit in one arm, you need to stop the trial and you break the blinding. But if you break the blinding, what is going to happen? Early unblinding invalidates trial and licensing procedure, and the use of placebo arm goes contrary to ethics guidelines, but should be continued. So you have found that the thing is good, just like I told you about the Tuskegee study, but you have to continue it just because the trial has to be completed. So a lot of counseling and many issues come up, and if you unblind the trial, the whole trial becomes, but for the individual, found that it is best, so I take benefit of that. So several dilemmas are there. So now once the vaccine is developed, then we have another issue. Should you make it mandatory or not? And there are some issues with that. Necessity and proportionality of the vaccine. Is the vaccine safe? And we have gone through all this in this in the initial phase. Only when the second wave came, now people are falling head over heels to get the vaccine. I'm going to skip over this because for paucity of time, this is so there are other challenges during a public health emergency, like logistics. Outbreaks tend to occur where that occurs and where the thing is developed. So these are then limited supply of vaccine. So then there are social challenges, there are scientific challenges. I can share this with you, and so that you can. Biggest challenge is, what is the end point? Is it prevention of death? It is prevention of infection. So many issues crop up when you have the key challenges and when you are talking of especially prevention in public health. But what I would like to, and all this is given in this book, Design of Vaccine Efficacy Trials by WHO. And but what they have highlighted, it is not just the RCT, there are several other forms, and each can be used, cluster RCT, which can be used. And especially they recommend that when the vaccine is being rolled out, you may use what is called stepped wedge cluster RCT. Now each of these requires of further reading and understanding. There are several types, so don't go away with the idea that RCT is the end all of research. And that is for regular intervention. But what about other, in a country like ours, where you have from Gomutra to arsenic alba to all so remdesivir? How do we test in a plural society? So these are other challenges. Is it imperative that we can do only RCT? So there are several issues which are there. I asked you another, so I'm skipping some of these. I'll just, what I'll do is, when you do a cluster sampling, sometimes cluster sampling is done when you spread over population, then it's very easy to do. One of our postgraduates did this, he did a cluster sampling. There's some just simple logistic issues. What they had to do is they had to pick children from each Anganwadi, but they followed this sampling method and then distributed from each Anganwadi. Took 4 children, 5 children. The process, what happened, She was running all over Pondicherry, and then it was a follow-up study. And because she had to run all over Pondicherry, she was spending more time on travel rather than following the children. And a lot of children were lost to follow-up. So sometimes you have to be very careful and when you design a study. There's some data collection challenges. I'll just show you that. I'm skipping over the, this is you would have seen everywhere. Queues. Why the queues? This is for immunization. The queues have occurred because when you go to collection, one of the biggest bottlenecks is for registration. My question was, can you use, what is a method you can use for registering people? And what was actually happening is the registration desk, in fact, I went to one counter, people was actually drawing lines on a register. In front of us, we were all standing in queue and the person was drawing lines so that he's creating columns, put down a name, age, sex, and so on. Do we need it? Whereas if a barcode reader is available, so we have to think out of the box. And if you have a barcode reader and you have the Aadhaar card was mandatory, all you need to do is the barcode reader and the entire data comes in here. I have got 2 data sets here and a little bit of cleaning and you have all the demographic data. Saves time, saves service. So please consider ways of data collection. Similarly, I had given, what about online form? And there is data collection software. So when you go to the field, I had at least 6 times that people came for enrolling us for COVID surveillance. They were using paper and pencil. No way can they analyze that. Whereas there's a multitude of software which is available for you, especially Kobo Toolbox. I like that quite a bit. These can work offline. Please learn to use these apps, think about them and use these apps for any study. This is EpiInfo, another favorite, because this EpiInfo can also do analysis within that. Online forms, they are low cost, real-time access, they have design flexibility. But, and as was shown by your group itself, I have a less than 10% response rate. There can be survey fraud and there can be self-selection bias and a sampling limitation is there. It's only educated population. And the biggest problem is anonymity in informed consent and non-responder profile. None of us take cognizance of non-responder profile. Please learn to capture non-responder profile because the first question when it's asked when you come to a higher level of research, when you go to other platforms, more standard platforms like the BMJ or others, the first question they're going to ask you, what is a non-responder profile? I have raised several issues. If there are some questions I'd like to take, because I'm going to stop with this before I conclude. Any other questions or comments, I would welcome.
Yes, sir. There is one question from Vishnubhat, sir. When people analyze data from public domain, many researchers appear to be analyzing the data in a similar way, resulting in duplicate publications. How do you avoid this?
That's a very tricky question. I would expect from Dr. Bhatt. Yes, because they are accessing the same data. So therefore, that is where you have to see that if they have already published it, then there's no point in doing it. Of course, there are plenty of journals. So you have to do your literature search is important to ensure that it is not something which is already done. Of course, you're welcome to do further analysis. That is fine. You can access the same data and do a different type of analysis. In fact, that journals want it that way.
No, I
have one more
this,
slide. Yeah.
Can I talk?
Yeah, please.
Why I asked this question? Almost papers are coming for review. Almost one paper every week. Almost same data they have quoted, same type of analysis they have sent for publication. maybe from different journals. So there should be some way of controlling this because they are wasting their time. Same thing is coming again and again. That's what I thought.
Yes.
But at present, I don't think there is any control over this.
No, and the
Actually,
public domain.
Sir, we
only
discussed
data.
this in that previous session, no, on systematic review and meta-analysis. You need to register. In fact, Dr. Vishnu Bhatt only said that we need to register these systematic analysis because we need to conserve resources to avoid duplication and all that. So, do we have such a similar registry for population-based research? I think that is what is
No,
the question, sir?
No, I don't think there's a, I mean, I'm not aware of that. I will not say that it is not there. I'm not aware of such a, but I think that's a good point that if somebody is accessing the data, in fact, open data source, they actually say that you download for what purpose, and you can look at for if somebody has already downloaded the data for a particular purpose, there's no point putting it there again. So there are a couple of sources. In fact, this open data platform of Government of India, you can do the visualization analysis and put it there. So it may be worthwhile to look at it, but that's of all in public domain. But if you want to do it as publication, it may be good to have a look at what has already been done. And same person trying to publish the data in two journals, that's not permitted. So that is very clear. But if same data is accessed by different people and published, that's a different thing altogether.
Yeah, that part I don't know, but it is all similar type of analysis like mortality, maternal mortality prevention, neonatal mortality prevention, control, all taken from our national health policy
From the same
website.
data.
They have downloaded the data and analyzed. Of course, now it is good, but it's almost similar papers from different journals.
Yeah, true. That's a
One
challenge.
question.
Yes, Dr. Mahalakshmi.
Sir, when we discuss qualitative studies, we were
Yeah.
discussing about mixed method tools, like you can try and juxtapose qualitative data and do quantitative analysis also of this. Do some similar thing exists in population-based studies? Why I'm asking this question is, I recently saw that very interesting interview by this journalist on COVID-related deaths in the wire. Just they are going in YouTube also. She was talking about how the deaths in COVID is almost 45 times more than what was reported in Bihar, UP and all that. And she tried to identify and compare it with what is in Tamil Nadu and other places also. And there she said that she tried to calculate how she came to this conclusion that the deaths are underreported. Something about surveys from individuals across this thing, plus a juxtaposition or interpretation from the data from crematoriums and things like that.
Agreed.
So that just kind of made me think, do we have some similar strategies to be addressed in public health research? The mixed method.
Oh, yes. Do you have time? I can ask Shiva to explain what he did. Just 2 minutes if you permit. Otherwise, I have to just very briefly tell. What do you say? Okay, I'll tell. What he found. I'll tell. Okay,
Sir,
I'll tell. You want to explain, Shiva? Just very shortly, you explain what you do. Two qualitative studies: the transect and the workers.
yes, sir. Madam, I used to conducted a study now for understanding the data flow of HMS data from the subcenter to the district level and analyze it to identify the reasons for the data errors. And I found almost 30 different errors for the occurrence of the data errors. And different settings.
Mix the methods. So he found that the data errors. Why the data errors occurred, he had to substantiate by qualitative study. He went and interviewed people at different levels, starting from the lowest level, the health worker, going to the highest level of the administrator to find out why the data errors occurred. The second one was he had mapped this information and found out the inequities, but that is a mathematical process. Actually, if you are there does it reflect what is really on the ground? So what he did is, he did what is called a windscreen survey. He just drove around and found out whether, and he found a very close relationship between his assessment by the mathematical process, that is analysis which he did, and this windscreen survey. So it can be supplemented. So you have to think and use the techniques, because population data is usually at a very big level, whereas you have to substantiate that by going into and studying smaller things, so that you what is called in qualitative research methods called triangulation. You can ensure that data points are similar. Any other questions?
We don't have any other question in the chat box as of yet.
I have just one more slide to show you.
Yes, sir. You can share the slides.
Yeah. So just in conclusion, so if you look at data, somebody has said, especially nowadays that we have large volumes of data. You go to a hospital, you can have for years, you can, thanks to computerization, you can have volumes and volumes of data. There is large data analysis is a different thing altogether. Of course, one important thing is that many hospitals that data is fudged. Mahalakshmi will know what I mean. Not her exam results. So there are 6 in big data analytics. There are 6 key areas: value, volume, the velocity, the speed at which the data. In fact, if you take clinical data, it comes at a very high speed. If you look at ECG information, is a continuous data. Large volumes of data are coming in. Variety, what is the variety in the data? How good is the data, and what is the variability within the data? So these are the 6 V's of big data. And to that, I have added one more V, which is called, it's not just sufficient. And I gave you examples of it, which is visualization. So when you put it all together, this is the challenge for us. And from here, this is the first step. And from here, when you start analyzing, and look at then you come into the realm of research, the ethics of research, and so on. Thank you very much for a very interactive session. I had to skip some areas, but then there was quite a lively discussion, so I had to miss some points. I can always share the slides with you, or any other further questions you can write to me. Thank you.
Thank you very much, sir. Thank you very much for that very elaborate lecture on population research. And I think research director, Dr. Vishnu Bhatt sir, will accept with me that when we do some analysis in the IRC, when it comes to hospital-based studies and sample size calculation, we get stuck up with cutting some balance between sample size and the feasibilities. But when you open that gate of the hospital and go out, there is an entire population to do the study. So that we need to take up more community-based studies. That's what we infer from this entire talk, sir. And thank you very much for that vision. And I take this opportunity on behalf of Arupati Medical College management and university, BMRF, and the entire crew to thank sir for spending his time and giving his valuable inputs.
Danny, one more thing. Sir was talking about research ethics. Now, sir, this is one very nice resource I found because it made a very interesting reading. They had taken case studies from Africa for various, mainly public health based research. Only thing is, it made the book very interesting in the sense that they used a lot of cartoons and other things for putting issues across. So that's a nice book if anybody wants to have a look at it. A lot of cartoons and interesting case studies from Africa on what you got, no? Vaccine issues. They try to analyze vaccines for malaria and things like that from real world studies. So that was an interesting book to look at.
Thank you, ma'am.
I have another very detailed book. If somebody is interested, I can share with you, which I downloaded. Some of the material which I pulled out, especially ethics, I can share that book with you. Of course, this other manuals of WHO are available. They are some of the latest ones. Surprisingly, disease X was named in 2018. They have already anticipated so many issues with the disease X, and we went through all those phases. So we could have been better prepared for such an epidemic. So that's a sad part of the story. Thank you.
Thank you, sir. And before we close this, I have two important announcements to make. The feedback link has been shared to your participant mail IDs, and kindly fill the feedback forms for today's session. And another important announcement is that on Saturday we have two important talks. One is by our beloved Director Medical Research, Dr. Vishnu Bhatt, how to write a narrative and scoping review, and another talk by Dr. Sri Kumaran Nair, Professor of Biostatistics, JIPMA, an introduction to Cochrane reviews, and thereby we'll be completing this research webinar series. So hope to meet you all at on Saturday, and we wish you all the best for a complete research webinar experience. Thank you.
Saturday timing also you can tell.
Saturday is 10 o'clock, sir. Morning 10 o'clock we'll start. It's a half day, sir.
Yeah. Because it is in the morning.
Okay.
So
Thank you, Danny.
shall we close?
Yeah, yeah.
Thank you very much, sir.
Thank you, sir.
Thank you.
Thank you.
Thank you, Dr. And thank you, Mahalakshmi.
Thank you, sir. Bye, sir.
And bye.
Danny will close the thing. Just wait for 1 minute.